the conversation. There we go, it's being recorded. The chat will be open throughout. So although we're going to ask you to stay on mute, particularly during the panel conversation, the chat is there. Please do use the chat, first of all, to let us know who you are. It's always lovely to know who's here and where you're from. But if you do have any questions, then please do use it for that. When we asked you to register for the event, we also asked you to send in some questions. We had loads, way more than we actually got time to get through today. So what we will do is get as many of those questions asked to the panel today as possible. Any that we don't get to, or any questions that you put in the chat that we aren't able to get to, we will keep, and we will keep a record of, and we will publish a blog reflecting on this, which will cover as many of those questions as possible afterwards. So anything you ask, any comments you want to put in will be incredibly helpful, and we will keep those and reflect on those and make sure that that's all part of the conversation in the longer term. I think that's all I need to do by way of introductions. So I can see we've got a nice lot of people here today, which is fantastic. Thank you everyone for coming and giving us your time today. We will finish by 1 o'clock, by the way. We've got a lot to get through in that time, but I'll make sure we do finish by 1. But first of all, I just want to bring in my co-host, Marsha, just to give us a bit of an introduction to the topic and why it's important that we talk about mental health services now and what we want to cover in this session. So Marsha, over to you.
Thank you. It's my pleasure as an ambassador and peer consultant at the Centre of Mental Health to actually be on this call with 4 amazing lived experience practitioners or experts by experience, some of who I follow actively on Twitter. So I'll let them introduce themselves in a minute. But and then I will start asking some questions. So this is the 75th anniversary of the NHS, which is really great. And the Centre for Mental Health and the NHS Confed Mental Health Network recently launched a report called No Wrong Door, a vision for NHS learning disabilities and autism services in 2032. And so I was actively involved in that, but I'm really looking forward to hearing some of what Doreen, Isaac, David, and Ellie will be talking about. So if you could each just quickly introduce yourselves. Ellie, could you say where you're from?
Yeah, hello everyone. Lovely to be here. My name's Ellie Costello. I am a parent with lived experience and have experience of mental health services myself, as do my children. I run a community interest company called Square Peg, and we work to raise awareness and affect change on behalf of all children who struggle to attend or access or remain in education. I work strategically at a local level and helped design a brand new mental health service for children and young people aged 14 to 25. We're the only service that is now running as business as usual, and we're smashing KPIs. I'm enormously grateful about some of my ideas that have been implemented there and then have gone national. Yeah, I've got lots of ideas, so I'll be quiet, let everyone else speak.
Thank you, because I know we'll find out a bit more in a minute. Isaac, where are you from and the work that you do?
Well, thanks, Marsha. Hi, good morning, everyone. So my name's Isaac, live in East London, have 4 dogs, a noisy husband, probably information that you're not really interested in, but I'm someone that really believes in the power of stories and do a lot of work around lived experience stories, particularly of those that have experienced mental health challenges. I'm really passionate about advancing equalities from my own lived experience when I started accessing mental health services. 1997, the wards were full of black men. I still go back to those wards, still full of black men. How have we still ended up in this space? And I think it's really important that we advance equality. So a bit about the work that I do.
Thank you. So Doreen?
Afternoon, everyone. Doreen from West London, born and bred, and a grandmother of advancing years now. And I am a peer researcher for a number of universities, a part-time co-applicant and PPI lead. I work with University of Oxford for two projects. One's coming to an end and one's just beginning. COPAC's looking at reduction and prevention of mental health outside detention of Black men. COPIX, which is looking at psychosis and multi-mobilities. And I'm also a peer researcher for City University for two projects again. One for Pegasus, which is looking at serious mental illness and cardiovascular disease and diabetes. And the other one is culturally appropriate advocacy. So that's what I'm doing.
Thank you. So David, and then I'll ask each of you a question.
Hi, I'm David. I'm born and bred Londoner. Half my life angry outsider, service user, still am. And half my life infiltrator, trying to create meaningful opportunities for people with lived experience at all levels in a workforce, not just as independent voice.
Thank you. And you're an author as well. A great book. Right. So imagine, with it being the NHS 75th birthday, each of you get given a blank cheque. So would you be able to tell me in about 4 minutes what you would be able to do with that blank cheque? How do you envisage services would change in the next 5 to 10 years, please? So how about we go for Doreen first, please?
Well, thank you. Yes, it's 75 years of the NHS. It's also 75 years of the Windrush, when the Empire Windrush landed in Britain and bringing lots of people from the Caribbean and the Commonwealth. And quite a number of the women that came were nurses in the NHS, without which it would not have operated fully. And unfortunately, they immediately experienced discrimination, being relegated to SEN, state enrolled nurse, instead of state registered nurse, which other white nurses had been awarded. But they did their best, and the hospitals were clean and all of that. Nobody got ill, picking up any diseases from infections in the hospital has happened recently. What I would say is, Isaac has noted, that the hospital units, psychiatric units, are still full of Black men and women and young people. And this has been the case since I've been doing research over 40 years now. And we have tried different methods, but I still think that there's hope. And I think also that we should try and decolonize the whole system, because it's still run on the premise of slavery and colonial mentality, and that really is systemic. It's all the way through the whole mental system. So we have to decolonize that, and we have to have allies amongst all races to fight racism. And also the dominance of pharma in the treatment of people with mental illness. And it's also trying to become global. So we need to look at more therapeutic and humane treatments and alternatives, holistic, spiritual, cultural, all these other ways of perspectives of looking at how to help people who are suffering mental distress. We're not criminals. We shouldn't be incarcerated. We should be helped, and preferably in the community. So therefore, money should not be spent wasted. No, I mean, okay, fair enough, people are incarcerated, but that's money that's spent. But better money would be spent, in the long run, would be better health outcomes in the community if early intervention, if working with family and friends and carers, working with faith groups, working with patients themselves, peer support workers, all of this. And if we employed more peer support workers in the mental health system, people who have lived the experience of being mentally distressed and know what works for them and what could possibly help somebody else, we go a long way to getting better treatment and care. And also when we are employing staff, to staff retention, better pay, but also culture appropriate approaches, recommend that we have people from the same background in the staffing as the patients, but it doesn't always guarantee people from racialized communities are it's definitely empathetic, because that isn't always the case. They may have been the training of Western ideology, which does not really work in favor of Black people. So when we employ staff, we have to ensure they have the skills that are compassionate and caring, and that they understand what it is from a lived experience point of view, what it is to experience mental distress and crises, and how it also impacts on your family. I'm a mother who's a single parent at the time I got ill. Well, I wasn't at the time I had my husband, we separated, but I was a single parent after that. And the social services had to get involved. It was a long traumatic whole episode, dragged on for years. But I had compassionate staff in the hospital who looked after me, and family and friends, especially my church family. And other experiences I had were negative, but the good ones that I had experience of, that's what I take as hope going forward to share with others through my work and through my writing. I'm also an author. My books are on Amazon, and it's about faith and about health and race. And really, we have a big fight on our hands. The fight is still needed because things have not changed as much as we had hoped they would for the last 40 years. Thank you.
Thank you, Doreen. Thank you for all that you've done and continue to be doing. And I'm sorry that you are experiencing that and it's still going on. So thank you. David, over to you. So you have this black check. What are you going to do?
Probably check whether it would be actually cashed before I use it. I distrust, like everyone else does at the moment. I'd like to come in slightly slant on this. So when I've had mental health problems in the period I'm going through at the moment, my relationship with myself has been broken. My relationship with other people, friends and family, is broken, and my relationship with society is broken. Who I was is not who I thought I would be. And I've also worked with a lot of patients, not just service users, but in other services. And what I'm struck by when I work with people who I call patient leaders, that's people who've been through stuff, who know stuff, who want to change stuff very broadly. I've noticed that they foreground relational qualities and connected care. So who better than us who've been broken to lead a system back into a humanized way of being? Who better than us can emphasize relational care and connected systems? Nobody in the NHS at executive level has that responsibility. They're all in silos. Medical directors, stressing clinical quality, nursing directors, getting to some extent on experience, managing directors really serving performance regimes. So I'd say we often talk about what should be fixed by them, those that in power, as if we're children and they're the adults who should sort it out. What if we were the powers that be? So I think what I want to talk about is power. I want to dismantle the engagement industry, which doesn't work. So the feedback and representational systems are a way of keeping us at arm's length. And I've moved into, following from Doreen, working with peer support workers. The problem with peer support workers is there's a glass ceiling. So there's no progression opportunities and people can't move into strategic improvement or governance or even leadership positions. So I'm working with mental health trusts to create lived experience directors, to create pools of service users who are involved in improvement and in governance, and to create career pathways for a new, what I'm calling an experiential practitioner workforce. So that's my work. Is how do we create meaningful opportunities for those of us who bring jewels of wisdom and insight from the caves of suffering? because we have leadership qualities, we have PhDs by dint of our suffering, which are not acknowledged, not accredited, not realized, not provided for. We go to boring focus groups on Tuesday afternoon with stale sandwiches and asked whether our families or friends would recommend a psychiatric unit. And we go in to be, quote, representatives and have to wear a tie and, if you like, become institutionalized that way. So I'm interested in a new experiential workforce, and I'd spend money on that.
You something I've noticed about you, I feel like you've smashed that glass ceiling, and I know that it takes a hell of a lot. So yeah.
Well, it's interesting, Marsha. I had and I hadn't. It's the Sussex MSK service that got me as director, patient director. Their two patient partners pursued me in when I left, so there was a legacy, but they've dropped it. So the very pioneering service that did that, for various reasons, no fault of their own, et cetera, but they should have done it. And so now we have some mental health trust picking it up. So the person to watch is Mel. I've forgotten her name. Mel, who's going to Midlands.
Oh, Mel Ball.
Mel Ball. So she's becoming a lived experience director in the Midlands Partnership Trust. Watch that space. And Leicestershire Partnership Trust, watch that space too.
Thank you. So Ellie, you're someone that I've recently followed on Twitter, and what would you do with a cheque? And I'd actually take you to the bank to ensure that we cash it.
Yeah, I think that's a really interesting point. Is it actual cash, or is it just a press headline that doesn't actually mean anything? So firstly, I would want to check as well that it was ring fenced, and that it was that the local area were empowered to do with it as they saw fit and had license, and it wasn't ladled with a whole load of caveats and you can't do this and you can't do that. I've actually been lucky enough to be part of a service design, brand new service under the Key Worker project as part of the mental health long-term plan, which was that all children and young people with a diagnosis of learning disability or autism could access a key worker. That's the aim. Well, it's any person, isn't it? But this was a youth-led, youth-focused service, which was there to reduce and prevent Tier 4 admissions. And there were several things that I learned from that. Number one, that it was the best example of co-production. And the reason for that was that co-production EBEs were placed at the centre of the bid and were prized at all levels. And what I've learned from the 8 years of strategic work that I've done, like David, endless focus groups and work streams and operational stuff, but actually unless you have at least 2 relevant EBEs at governance and oversight at board level, all of that great work that happens further down often isn't voted on, isn't appreciated, isn't fully understood. So I completely agree with what David says. We have to treat and value EBEs as consultants. And I think if we sort of think of consultant level care, think of consultant level experts by experience, you know, this is invaluable knowledge. And so for me, I completely applaud with it and agree with everything that he said. It's got to be place-based, appropriate, and without a load of caveats attached to it. I think I absolutely agree that we need distress-led services, and that where patients are empowered to find their own pathway as well. We know that when patients, people are empowered in their own healthcare, particularly their own mental health care, actually the outcomes are better. So we've really got to stop this, framing of, we know best, and actually listen to the people who are in distress. Obviously, then there is the, my key focus is on Tier 4 primarily. I'm concerned about with peer support models that there's a burden on peer support and practitioners, and that actually it just becomes a sort of sticking plaster where there isn't a sort of next tier up, or there isn't, anywhere to go. And that's why I think peer support expertise does need to go right the way up the channels. I was thinking about tier 4 care though, and we talk about beds usage and all the rest of it. It's a very singular sort of way of framing things. But my big idea, really, I suppose, what I'm thinking about, and one of the ideas that I took into the key worker pilot was that we don't have a discharge model. So I used the example that was my son has several rare conditions and is under consultant-led care for life, and he's not perpetually discharged. So in fact, he's just held at a consultant level as well as a GP level. And at the point that we see escalating healthcare needs, we're able to step back into that specialist service. The KPIs that have come back from service users within the key worker pilot, from families and the young people, has been, this is invaluable. We know that we are held somewhere, we're known, and that we're safe with this service, and that if we need to get back in, we can. So I think that for me would be something that is already being rolled out, I'm pleased to say, but I would like to see that held elsewhere. And then thinking about tier 4 care, again, just sort of applying my knowledge and my lived experience. I had a parent who went through end of life care, and there's something really rich in the palliative care model in terms of offering care within the home, and actually having, we had a palliative care nurse who was there over the night shift, if you like, and was there to administer medication and observation and care so that we could get some sleep. So I think there's something there, if we are to look at what is already going on within other parts of the NHS, that we can innovate and replicate, but it has to be distress-led. Relational care, I absolutely agree with, and it's got to be compassionate and enables our populations to live with dignity and respect. And actually what happens within mental health so often, if it's this top-down model of doing two, feeling like you are under a lens, which is even more destabilizing, and the threat of care being taken away. You're not able to access this, so we're going to discharge you, and it's always framed as the patient refused to. So we really have to absolutely stop. So for me, EB consultants at all levels, particularly board and governance, not just one, but a pair. They need to tag team. So that's my idea.
You've got various hats. You've got the carer, you've got the mother, and that. So thank you for trying to get all that in the 5 minutes, and thank you for all that you do. So Isaac, you get the check, but I come with you with an armored car, we cash it, and then we get the armored car to go to the various bits where you want to to make sure that it has maximum service and that. Where would you do? What would you do?
The first thing I'd be wanting to explore is what comes along with this money. And for me, there needs to be reparations and acknowledgement of the harm and damage that the NHS and certain professions have done in the first instance. I would say that I would be keen personally to dismantle the very systems that we're talking about, because I think they don't work. But actually, this isn't my money to be spent. So we would need to agree as local people and communities how this money is best spent, and that would need to be done in a way that everybody has voice, everyone has the opportunity to decide. Very much keen on that kind of participatory kind of approach. I think it would certainly mean that people in a particular place or certain groups of people would be deciding what's right for them. I think rightly so, that would need to be facilitated and supported by people with lived experiences of accessing mental health services. I think often people like myself prevent that kind of blue sky thinking because we are rooted in such a rigid, negative trauma kind of space. And what does different really look like? Is it investing in the very systems, creating systems that have people like us talking about having directors and EBs, and actually why not do something really different? Is there a need for people like us to be doing this work? Yes. What does that feeling look like in the future? Who knows? Certainly, we need to address the power inequality and imbalances that exist even within the work that we do. How do we encourage innovation and different kind of ways of thinking that matters and makes a difference for people? And I think, like the other panelists talk about kind of the role of people with lived experience. You know, we know it, we feel it, we breathe it, but we had limited power. So what can we do to invest in people? How do we get people to you know, call out some of the things that are happening? You know, how do we transact some of that power? How do we actively disrupt the status quo? And I think for me, that would definitely take a racialized lens. It would definitely take a, you know, easy to ignore lens. It would be very inclusive, but more investment in people with lived experiences, driving forward whatever we co-create. But actually, it's about good lives, and not forgetting that this is about people being able to have good lives with purpose and meaning, regardless of your experience, regardless of where you are. I would want this to be something that exists where I live, but actually it is possible where Doreen lives, or possible where David lives. It should not be a postcode lottery. And the thing that I think we always need to be doing is really watching ourselves. So who's watching us on this process of spending this money? How do we make sure that we're doing the right thing? And how do we do it in that way that is really human and embraces the messiness? And I will talk about co-production, obviously, but you can't do it without co-production. You can't do it without lived experience. And we would need very different conversations.
Technology. I have got 2 more questions. However, I can't ask all 4 of you them, so I'm going to choose, and hopefully, so if you answer like 1 or 2 minutes, if that's okay. So so Doreen, so what are the main barriers do you envision services have to overcome, and how can it be done? So you've been doing this a long time. Do you see the same cycles in that, and how can you overcome that? What are the barriers?
Firstly, answering Ellie and Isaac about power. So for a long time, people would say about empowerment. People had power before they entered into the mental health system, except when they get in there, they are treated like children and given the status of children. So that's why we have to be empowered. But we had power initially. We had agency before we got sick. And then the other thing is, Ellie was saying that the fear of getting discharged and not getting treatment. Converse is true for Black people. The converse is true in that we have fear of being detained in these institutions, not being discharged when we should be, and get support that we need in the community. Even with IMHAs, independent mental health advocates, saying the carrot and the stick is often offered instead of trying to help people negotiate their way back into living at home in the community. But you say, what are the barriers? I would say conversely, what are the facilitators and enablers? What would make things happen? Because we all know what the barriers are, and they're all giving the excuses why things shouldn't happen, why change shouldn't happen. But having people with a decolonizing approach, i.e. having anti-racist approach, having anti-marginalization approach, actually appreciating people for who they are as individuals, as full human beings with mind, body, and soul, not just looking at the mind, siloed, isolated, one part of us. We're complete human beings, mind, body, and spirit, we are souls. So then that means you have to look at ways of looking at a person holistically. So that is part of the equation, and looking at alternatives, other, not just a Western medical model, but other alternative cultural alternatives, how people introduce spirituality or care or faith, whatever it is. I don't know, nature for me, eco therapy works for me, art therapy works for me, music therapy works for me, but also my spirit, my faith works for me. So these are enabled, and also support within the communities, because as Paul Gray said on another piece of work, I think he was part of the Breaking Circles of Fear back 20 odd years ago, which I said had anniversary last year. And he was saying, the community rallied together, especially like on Broadwater Farm when he was a teenager. Out of the ashes came resilience. People have assets. Part of lived experience is having assets. The resource within yourself, or with a resource from other people supporting your network to help you maneuver through life's difficulties, especially when you're at your lowest point. Yeah, so that's what I would say. Thank you.
Thank you. So before I hand over to Andy to ask some more questions that came in, I just wanted to quickly go around Ellie, David, and I'm sorry. I'm so sorry.
Isaac.
Isaac, I'm sorry, Isaac. For some reason, I wanted to call you Samuel. I got mixed up. It was the wrong way around. I bet you some people that are listening would call us a cynic for what we've said, but it's real. We're being real, aren't we? We're being honest. So all that you know, what would one change would you want to see that could real have impact on the ground now? So Ellie, what would that be? What would that one change have impact?
Check your professional hubris. Remain humble and believe the person sitting in front of you. I think there is such a culture to dismiss, deny, or to reduce, somehow minimize someone's experience, and that is actually more arousing and more activating and harmful, and it escalates needs very quickly. When you don't feel trusted or believed, your voice isn't valid. So for me, it would be about checking, your the power imbalance, really being aware of that, and remaining humble and curious. For me, some of the best care I've ever had has been with people who, because I've got a kid with rare conditions, we've had to puzzle through it together, and actually, my status, if you like, as an expert in my child, I either experience you're an over opinionated, highly anxious, fabricating, inducing parent, or you're an expert, you talk to me, I want to learn from you, and the latter is definitely where we have stabilized, put a plan in place, work together, everything calms, we're empowered and respected. It's respectful healthcare, isn't it? So I think it's the one thing, we see this in education a lot as well, and other services. It's very difficult, I think, for professionals to really hold on to that humility, because they're there to do a job and a role, and all the training kicks in. And it's also really difficult to hold the tension that you might inadvertently be adding harm. But actually, if you're able to sort of get within the nuance and keep yourself humble and curious and courageous, and at the same time as being respectful, that for me would be a massive culture shift towards respecting the experience of the person who's coming to you to ask for help. There's nobody particularly wants to do that for kicks, and they're not doing it for kicks. We're coming because we need help.
Thank you. So Isaac, who I almost renamed as Samuel.
That's no worries, Marsha, at all. For me, it's about connecting with the emotions. I think often emotions aren't part of the work or the experience, and actually people's emotions are invalidated or used in a way that is really unhelpful. I think when we connect with our emotions as human beings, fellow human beings, with the experiences that people have, it enables us to really understand people's journeys, and it enables us to support people in the way that makes sense to them. I think there's a lot of professional service fragility that happens. And actually, if you recognize that people are experts in their own lives, and the emotions and experiences they bring are not stuff that you shy away from, are stuff that you should step into and embrace, I think you're much more able to support people. Not forgetting that we don't want people to access mental health services. What we want people to do is live really good lives. and we need to tip this all on its head. So I talk a lot about health creation. How do we create health, or how do we create public health, where we are supporting people to have really good mental health regardless? How do we recognize that some people, because of the nature of their identity, their skin tone, or their sexuality, or the fact that they're a carer, have very different experiences? And how do we actively minimize those barriers? Really important, but totally be emotionally led.
Thank you. So David, what would you want to see on the ground now, right now? What would have real impact?
Okay, first we need to recognise that staff are on their knees, right? That they are demoralised, and a workforce plan comes out which doesn't tackle retention. So the fear of our anger and how much we want to change, and the lack of influence that staff have to change things, for me, the user movement has to step up. I think we have to stop for a while, or package our anger in ways, or reframe what we bring, because everyone has said it, but they haven't made it quite explicit. We can help. And that's the point. We've got a lot to change, and we have to equalize power, but we have to recognize that staff are on their knees. The system is fragmented. We can help.
Thank you for acknowledging that. I agree. And Mel Bow, she's moved now, hasn't she? I can't wait to see what happens in the next few months in that. But got to acknowledge that, David, you've been doing this a long time, and you were one of the pioneers and still are. So thank you for what you and Doreen, Isaac and Ellie have done. So Andy, I'm going to pass over to you now, because you're going to answer the questions. You're going to ask the questions that were sent in.
I'm going to try and answer or ask some of them to members of the panel. Marsha, thank you so much for hosting that conversation with our amazing panel, and thank you to Ellie, Doreen, David and Isaac for your really thoughtful and moving answers to those questions. It was a real privilege to be able to hear that, and I know people listening to this will feel similarly. We asked people for some questions in advance. I'm going to select a couple of those, can't get through all of them, but I think we have now opened the, or we will be opening the chat, so you can post your questions there. My colleagues will tell me, I'm sure, if I've got that wrong, but I believe that's right. So the first question that I thought may be relevant to actually what you just said, David, and I think it's worth thinking a bit more, came from Yasmin Rivera. Yeah, Yasmin, thank you for the question. And it's really, how can change occur if services can't recruit people? We know we've got a massive work crisis. We have actually seen more people working in mental health services, and numbers have gone up, but the need has gone up even faster. And as you said, David, people are experiencing burnout, people are experiencing really difficult, awful working conditions. So I think it is, I don't know if any members of the panel want to pick this up, or David, you want to kind of expand on that. How can we support the workforce that is really struggling right now? A lot of the things we talked about, and you talked about, take time, take reflective practice, take working in a system which is a lot calmer perhaps than the one we currently have.
I don't have a magic wand, Andy. The thing I would say is that the criticism of the government workforce plan was that it looked at recruitment but failed to look at retention. So I think retention is actually the biggest thing, and to help people already pushed staff. So again, no magic wand, but in the service I was working on, which was pre-COVID and during COVID, the physiotherapists and allied health practitioners came to us as lived experience practitioners because they said, well, you've been through trauma, can you help us with our well-being strategy? So what was staff engagement? What was patient engagement? It was all muddled. We all came together as human beings, and our experience was valued. And we created a a well-being strategy through COVID and beyond that went beyond table tennis and mindfulness rooms.
Thanks, David. Doreen, I know you want to come in. I was amazed that the workforce strategy didn't acknowledge trauma or burnout. It had some nice words about well-being, but it was not really touching the sides in terms of really understanding what people in the health and care workforce have been through over the last 3 years. It's quite extraordinary. Doreen.
Retention. Well, yes, money. You have to have some money. That's part of the blank check. We have to have some money to pay staff properly. The cost of living has gone up, energy prices have gone up, everything's gone up, absolutely ridiculous, except the wages. They're actually impoverishing people. Even people who are middle class are feeling the pinch. So that's the first thing. Secondly, work condition, not having stressful 12-hour shifts, 8, 10 now, 12-hour shifts, and having support in the workplace. If you see something that you think shouldn't be happening, you're concerned about, you see something going on with patients and staff, or patients or staff and staff, whatever it is you see, you should be able to go to somebody, line manager, supervisor, or some organization outside your workplace, or the union even, to address these concerns, and not be fearing that you're targeted as a whistleblower and that you're going to be subjected to I don't know, have your tires slashed or ostracized or whatever. Similarly with patients, if you see something, patients and staff on the ward situation see things, hear things, witness things, some of which is very disturbing and in itself is traumatizing and re-traumatizing. Patients should be able to speak to somebody about it without fearing that their treatment is going to be impacted negatively, that they're going to be secluded or worse. So I think put money in it, put resources, put support packages in, away days, holidays, things like that, build those in, because we are I think we're still a first world country. We can look after our workforce and employ people who have lived experience, peer support workers, but people in the members of staff people who have lived experience aren't just or imbeciles, as I think we're treated as we're imbeciles, that we have no skills, that we didn't have a life before, that we weren't employable before we got ill, that we're not employable after we become ill. Some people had degrees, postgraduates, before and since after having mental illness, and have held businesses and top positions. And so these are assets that you can harness and employ people as such in key positions. And as David was saying about the leadership roles, we have peer support work, I guess, was it level 4, band 4, maybe band 5 if you're lucky. What about the higher bands? Years ago, there was somebody who first talked about lived experience, and she was a director of an organization, and she was given reasonable adjustments. Whenever she felt poorly, she was given time off, or she went away for a few hours and came back. So that was years ago. Why can't we have that as a standard practice? Thank you.
Thanks, Doreen. I think it looks like you want to come in just to say it's extraordinary. We have to say that it should be safe for people to whistleblow. It should be perfectly obvious, and yet we do have to say it does have to be said, and both for staff and people using services and indeed family members. And I think recent reports around poor standards have shown that it is necessary.
Thanks, Andy. So if we've done everything David's talked about, we've done everything Doreen's talked about, what will that lead to? And I think that we need to maybe tackle some of the very reasons why we've got to the places that we've got to with investment around mental health, which is often about the undervaluing of mental health services, about stigma, prejudice and discrimination. So I think there needs to be a serious national debate about what do we want our future mental health support to look like. I think that this is probably not going to sound very nice, but it's a very responsible job and not everybody's suited to work in mental health. if we start thinking about the values that we want our workforce to have, and how we create the conditions around those values. Clearly, people aren't able to do the best that they want to do because of lack of resource and support. But in the future, I do think we need to be looking at the values, recreating a different narrative about mental health services and support. It's not all of that trauma, all of that kind of negative stuff. It's enabling people to live their best lives. How do we have that national kind of conversation where proper resources are available to support a workforce do their best? And how do we start shifting some of that power where actually that workforce is representative of the communities it's serving? So 50% of people employed would be my dream as a bare minimum, with lived experience in any one trust, and beyond. I think the more we employ and support people that have had experiences, the better things will be. So that would be my take on it, value-based approach.
Thanks, Isaac. That's some really interesting responses, and again, I think some really creative approaches to what feels like a next to impossible issue. We got a question from Sarah Ellis, and actually we got a number of similar questions from Sarah. So thank you, Sarah. Talking about the fact that very often, by the time a young person meets the threshold for support from children's mental health services, they're often in crisis. We see this time after time after time, and Sarah's asked what can be done to support the system and families a lot better. And Ellie, I wondered your thoughts on that. How can we move towards a system when everyone is running to stand still, where we really do intervene early, support families early, and help children to have better mental health from the start?
Yeah, so I think this would pick up on what Isaac was saying about culture and values. So, for families and young people who are in distress, they're often blamed or identified as the cause of the problem. And, I think we need to start calling out childism and parentism is a phrase that I'm now coining because I can't put it any way else, but we have a really unfavorable view of parents. It just trips off the tongue all the time. It's poor parenting, lazy, feckless, or pointy-elbowed and entitled. We're never ever doing enough. And so our views and perspectives towards children's distress, just like we see in adults' distress, is to blame, shame, reduce, minimize, dismiss, deny. And I think, if we can start skilling professionals with noticing their own emotional state and actually understanding, we don't have a strengths-based mental health care system, in that recovery is possible. And you learn from it, and not that you learn from it, but that it is an asset. It is something that you can take into your life and help educate others. So for me, the sort of biology of hope around mental ill health is something that isn't talked about. So for me, it's that, normalizing distress, being comfortable with feeling uncomfortable if we're seeing distress in others, and actually being kind to ourselves. So one of the things, I had a brilliant discussion with someone who said, it's normal for us to feel afraid if we're in the presence of someone who is having, some sort of episode or meltdown. It's normal for us to feel afraid and to want to step away. But actually, we can use our awareness and our thinking and draw on our professional training to kind of go, I'm aware of what's going on here, but I need to step in. And actually, what this person needs is support and care and to be listened to. And so those skills in terms of de-escalating and trauma reducing rather than trauma inducing, I don't think are skilled. We're not actually teaching those relational tools to understanding behavior and the science of distress, and also the biology of hope through healing. So for me, there's so much there, particularly in our response to children who are experiencing distress, in terms of believing them and validating their experience. That if we could shift towards that would be a key shift. And I'm also very briefly worried about postcode lotteries and lotteries within postcodes. You know, you can have hubs that operate very differently. So, you know, there needs to be a more cohesive planning and delivery of how we do it. But finally, we all have the opportunity within ourselves to reach out to people and to be their anchor or their safe harbour, so long as we are scaffolded and supported ourselves. So, yeah.
Thanks, Ellie. That's a fantastic answer. And there's been some good conversations in the chat as well about this and the particular role of primary schools, which I think is really interesting and important. I don't know if any other panelists wanted to come in, particularly on children's mental health. If not, then there's a really interesting question from Doreen.
I just wanted to quickly say, what did I write down? I wrote down lower the threshold, because the question asks about by the time the young person meets a threshold for CAMHS. So what? Yeah, lower the threshold and ensure that enough staff are employed and peer support workers are in place to support the young person in need. So that's two things: lower the threshold, because yes, the demand is high already, and if you lower the threshold, it'll open more floodgates. If you put money into resourcing, employing staff, retaining staff, and people with lived experience, peer support workers, lived experience staff at all levels to support the young people, then, you know, that's the way around. Thank you.
Thank you. Absolutely, without question. There was one more question we got in advance that actually I thought, Isaac, you'd have some interesting thoughts on, because you talked about reminding ourselves that mental health services are there to enable people to live good lives. And we had a question from Claudia asking, how can we ensure that data gathering is truly reflective of people's experiences of services? And it kind of begs the question, if we talked about how services should look, how can we hold them to account? How can we see that they're able to do that? What would it look like, and how would we know?
Brilliant. Thanks, Andy, and thank you, Claudia, for the question. So my simple answer would be people with lived experiences, quality checking, making sure that they're auditing the very services that are being. So we've gone through that code design, code delivery, and actually co-evaluation of services, but doing that in a really inclusive way. I think sometimes we ask questions that we already know the answer to, or the ones that we're comfortable with. When you have people lived experience, they'll tell you what kind of questions you should be asking in the types of ways. And actually what people want to see is when we respond and we share our experiences, it makes a difference. And often we share our experience time and time again, and it makes absolutely no difference. So how do we use people's experiences to create the change that we want to see? How do we ensure that is a really representative and diverse kind of challenge to the system to be better? I think only more investment in quality checking and people with lived experience being involved in that process will serve that. Data, really important thing that we can use. Often there are so many missed opportunities, so everybody should be asking people about their experiences, not just when they're trying to get a survey out, or not just when they're kind of looking at you know, someone visiting like the CQC or something, you know, like something like that. It's a continual process.
Thanks, Isaac. We've run out of time for questions. We will be gathering all the questions we've been asked and responding to those as best we can after today. And I know this is going to be an ongoing conversation. But Marsha, I wanted to invite you just to give your reflections on what you've heard today and how you're feeling right now.
So I began my patient voices journey in 2013, where I recorded a short video, and the trust that I was under at the time, the decision that I was on a service user carer group, but they were coming to us and the decisions were already made, and so I stepped away and did some work around personality disorder and stigma. I became the ambassador and peer consultant at the Centre for Mental Health. I was then on the NHS Confed, the Mental Health Network Board, as a service user rep. More recently, I'm the vice chair of the Mental Health Network. I'm someone who's still very actively using secondary mental health services. I'm hopeful that things are changing. However, those questions were the ones that I asked, that it was me that thought them up. And because those were what I've experienced over the years. So I take my hat off to you. But one of the things that I said to the Mental Health Network board is I didn't want my role to be tokenistic, and that I wanted to look into how, you know, how the workforce gap is widening. Imagine if we get to do some of, David, what you've been wanting to do for years, getting that proper infrastructure in place and there being reasonable adjustments and everything. While I'm doing what I'm doing, I'm on benefits still. I'm doing like things that it's never ever, but I'm in the benefits trap because I've got physical and mental health needs and I access domiciliary care. So, and then I have to contribute to that. But imagine if we could work creatively together and make it a safe space for people to be supported. And I mentioned the No Wrong Door, a vision for mental health, learning disabilities and autism for services in 2032. And everything that you said, we captured in that. So there's so much more to do, but I just wanted to thank you, Ellie, Isaac, Doreen, and David for all that you do. But it is a personal cost in that. But hopefully, collectively, we could elevate the discussion, because Andy, it's not over, is it? We're going to continue this.
We certainly are, and that point about this being an emotional labour is so important, and it has to underpin everything. I don't think there's anything more I can or should say apart from thank you. Thank you to Marsha for being a fantastic co-host. Thank you to our amazing speakers. Thank you to everyone who's come along to this, been part of it, given us your time today. We do appreciate that. We do not take it for granted. We've put details up about our next and final event from the Festival of Ideas, which will focus on the climate crisis and mental health. So please do come along to that if you can. And thank you to Hannah and Zach and all the other members of our team at Centre for Mental Health who put this event on today. Couldn't have done anything without everybody who's part of this. So thank you to everyone. Thank you for being part of this today, and take care and stay well.